Muy buenos días.
Good morning.
Invito a la doctora Alicia
I
Framarin.
invite Dr. Alicia Framarin, our first speaker today. Dr. Alicia is a medical doctor with a master in health services from Canada, and she is a scientific researcher in Quebec, Canada. Alicia will speak on systemic approaches for COVID. Good morning to everybody, and I would like to thank you and the organization of the INESSS for this meeting and for the invitation. It's really a pleasure to be here with you. For some of you that know me, you know that I have from a long time now technology in my mind all the time, and I like to share with you this topic with the other partners and friends and see the evolution and the work in Latin America, because I think I am a pioneer in the terms of technology in Latin America. For many years now I've been cooperating in this area, and thank you very much again for your invitation. Before starting, I would also like to thank two of my colleagues. I took some slides from them in order to make this presentation. Dr. Duncan, he's been working for many years in the institution INESSS, which is the Excellence Institute of Canada in Quebec, and Dr. Veranderi. She was my director and my colleague for many years, and she has lots of experience in this area. Together with them, I prepared the presentation. Regrettably, they are not here in the INESSS, but they continue to cooperate in this area. As you know, the evaluation of technology is a social activity. I always thought there is ability to share, not as in the research where we keep everything that we find out for ourselves. In the question of technology, there is generosity in disseminating knowledge. I will come back to the topic because I have a defect. I like to speak, and sometimes I speak too much. If you control the time very quickly, in order to put on the table from where I come, I am Argentinian. That's why my love for Latin America. For many years now, I'm working in Canada, in Quebec. And Quebec, Canada has a system, a political system, which is very similar to that of the Argentine. It is a federal system with autonomous states or provinces. For example, the federal governments provides the great guidelines in terms of the country in order to provide for uniformity, but each province or state make their own decision on what they are going to cover, they're going to finance in terms of health. In Quebec, now I'm speaking, concentrating on Canada, in the province of Quebec. It is taxpayers fund the system. With the years, I have been able to see that there's also the private services. 70% is a public system and 30% private system. They cover odontology, the private, lenses, physiotherapy, and all those treatments that generally are not covered. And also an important part, which is that of medicines and drugs, and which is covered sometimes by the patient through participation. that makes the 40% of the overall. Health represents 40% of the national budget, so health and education, and the two ministers will have the great majority of this budget, and 60% due to medicines and prescriptions as well. This represents around 7,000 Canadian US dollars. The society is a plural society. In Canada in general, the great majority is constituted by immigrants, and the professionals that are associated in organizations that will be part of the public, that will advocate the professionals. Well, this, I guess, for you is a very well-known topic. Whenever we talk about technology, we have a definition that's a very wide definition, not only devices or medicines and prescriptions, but the procedures and the systems to offer the services and everything to improve health and life quality. And this is a definition from a document that comes from PAHO, or WHO, correcting. And in such a way, it's nice to notice what. So the assessment on this technology, we are going to have an overview, is a systematic organization from the effects and impacts of technology that sets the consequences that are those that are foreseen for sure, and the indirect ones that are not foreseeable. So we should have information on a national level on health and the assessment of technologies and working groups. So working groups must have a role, must fulfill something. We should not spend our time whenever we go for a technology assessment is to assure the excellence in the or throughout the interventions. We have to avoid losing time. We know that on some decisions that we have to make over funding and other issues, the appropriate use of this technology, innovations that sometimes are not good enough for our context. Technology is a hard task for me. Well, which are the features of technology assessment? At first, should think about the scientific practice and knowledge and the experience of the local actors, all the stakeholders, in such a way to use it in a local context. For so many times we had assessed technologies using the literature over the costs, for instance, but currently if we can't do this, if we can't use all the actors and all the available technology, what can we do? We have to interpret all information we have within a local context. We use a transparent and local because scientific restrictions must be known, and this, if we make the decisions, we are going to lose time. We have to help also some decisions. There are several resources for technologies, and we have to make some decisions in one direction, and some decisions should be made in other directions. But we have to be free from the stakeholders, I guess, whenever we are working in group in such a way that discussion should be transparent and free. All the methodology should be published, the reports as well, in such a way that everyone can know the recommendation and the best way to reach the recommendation. Well, the regulations are different from country to country, but I think it's important to mention that for us, the technology assessment is not regulation, and it is not a way of managing. No, it's a complex or a mix of both, and we come we start studying from innovation till the obsolescence of that methodology. In the 70s, we started to assess technology, and with the problems of PEPSCAN, we had a committee from the United States Congress that, well, they had to label technology assessment to incorporate all of them in the system in such a way to be divulged throughout the system. This is Canada, just for you to show. Quebec is in green here. In Canada, we have some agencies, independent agencies for technology assessment, and they are oriented to upper level, oriented to the government. And when I mentioned that there are other agencies that are oriented and guided to the health professionals. So there is a concentration in Alberta. We have several agencies. In Quebec, we have several agencies as well. We have federal one in Quebec, and in Ottawa we have. Well, I will not take a lot of time here. 40 years we have on technology assessment. In the institute where I do work, we have two different branches doing the same work with 7 concepts around the technology assessment. And this is a national agency that works since the 80s. They are not dedicated to medicines. This is under other umbrella and other organizations' supervision. In 2011, January, the government has decided for an act, and this act mixed and merged medicine and technology assessment to create this new institute. And the council was already there by act. The Agency for Technology Assessment was created by a decree. And this, what I mean with this, we have several levels for considering this, but the institute where I work for is a result of an act. I would like to highlight as well, because it's important, this resolution, this ordinance from May 24, 2014, that acknowledges the importance of the technology assessment in an independent way. I will not read the full ordinance, but it is important. Pay attention to the word independent, because these ordinances as well, in the second paragraph, mentions that technology assessment could bring and should bring reliable information and reliable evaluation and assessment. Just for you to know that how we should work in an integrated way and what should we do for that. Finally, I should not mention finally, because we have several bullet points to highlight. But the World Health Organization is concerned to have a document over the assessment with all the countries that we work with. Some decisions are made without the suitable information, but the developing countries happen the same way and behave the same way, because technologies in number and quantity do not have enough resources, enough financial resources for the assessment of all of them. Why should we use technology to support sanitary coverage, to guide the appropriate use of technology or intervention or creating and generating value? How could we improve the quality of life of the population? How to integrate services, medical services, to assure that some interventions should not be used anymore. It's easy to aggregate, but if we don't behave this way, we have to fight against several bodies and cultures and so on and so forth, and we are going to face more resistance. And to favor a social context, for instance, and the fact of having all the stakeholders on the table or around the table to consider their points of view, generating a consensus, a social consensus. Now, this is a very well-known image. It's from a document from the World Health Organization. I would like to highlight the differences between regulation, and that is the origin of this technology assessment. And here we have the technical area that shows efficacy in a theoretical way before entering the market using this technology. This is worthy in such a way that the regulator body tell us if it's good, if it's not causes damages to anyone, and that we can sell. Now, if we go within our local context, how shall we profit considering costs and considering health? And then we have the technology assessment. We can do it in our local context, and afterwards, how can we use? So this graph can show our local context. This is hard to export whenever you have a review or some papers or a systematic review, for instance. If it's worthy for everywhere, but we know that we have differences that work as barriers, so we cannot simply transfer. This is something that my colleague has presented in another Congress, and I think it's very important. We cannot have technology assessment without human resources prepared for that. Sometimes in Latin America we have shared some activities on human resources, and in Brazil we have wonderful human resources. You have the knowledges needed for this, and I do not mention only Brazil, but South America. We can accomplish that only whenever we have the decision makers, but if we don't have them, okay, it's the efficacy is to bring an universal coverage, so we have to have policies for that, and directly interested people, and I mean everyone, the patients, the citizens, it could be the industry as well. We call a little bit less the industry, but in some places we use this criteria to generate, as I've told you, a consensus that could allow technology assessment to be useful and practice. Well, we have some challenges that are the same in every country. The growing demand of attention and services, the complexity of the people needs, and the protocols, the complexity of the protocols. We want, and the economical reality, we want to work more with less funding, with less money. We also have to consider the aging of the people, of the population. We have also to deal with chronic epidemiologies, so we have to take care with the lung diseases, cancer, and others, and the technological transition. The world is a smart world, intelligent world, so innovation and it pushes us in such a way, and we talk about precisely and accuracy of medicine for diagnosis, to bring treatment, a dedicated treatment. There are no limits for that. We have to set the limits. Here to show you, as I said before, the life cycle of technologies. From my viewpoint, there is something that pertains to the authorization for marketing and selling, which we call the regulation. And then when the technology is on the market, there is a technology assessment that can be done very early in time when you do not have lots of information, in order to know if within our context technology is useful. If we can repeat it, or we may have it there when it is no more innovative any longer, or if we want to disseminate it through the system and after the life cycle in order to take it out of the system or of the funding system at the end of its life. Sometimes this is, in some cases this is not done, and all technologies continue to exist and to work. In this same order of ideas, innovation is essential. And I believe, and I'm convinced, that technology assessment has a very important role, not to stop innovation, but in order to frame it, to have a frame, in order to avoid disseminating it excessively before we have all the measures to control the situation, and also to do all the tests necessary. And in the following life cycle of dissemination, the appropriate or proper use. If technology if we don't use it well according to the indications, we are going to use it not properly. And finally, obsolescence, lack of use. There is a criticism against assessment agencies because they don't systematically monitor this package of services of obsolete technology. Even in England, that for us is the model, this was criticized. At present, there is a change of paradigm. I don't know if you know the initiative introducing widely in the United States that now has gone north, and we have it in Canada also. And there is an effort of all the medical associations in order to have a reaccommodation on 10 technologies or that are not longer user and the use should be ceased. This is very well done and is very useful. I have some other examples, and the INESSS, specifically from 1 year now, the ministry said that we were in charge of assessment, the pertinence and the usefulness of the identity. We were very surprised because for us that do technology evaluation for many years now, we were always assessing the use of the technology properly. But today is the magic word of decision makers in the ministry. That means to say, there is some concern about it. This is an example, as any other example, the analysis and of vitamin D in Quebec per year. Is vitamin D from 2005. In the last 10 years, from 16,000 analysis on vitamin D, now we have almost 300,000 now. And there is no modification in terms of epidemiology, no weather change, nothing has changed. But anyway, this represents $3 million, and this is an example in terms of laboratory analysis, and there are others. With this example, we saw the need of having a small exercise on the proper use of lab analysis, and we did it and we published it. It's appropriate use of 14 lab analysis. It was very successful indeed in Quebec, and we did it together with the professional associations, with experts, with people from laboratories, and they issued this document and they copied to the colleagues, and in every single laboratory they know these documents. Biochemistry expert, they ask about this analysis, and these are 14. We should do the same for many laboratory analysis, but as I said, the effort is of the technology assessment has a limit, and we have to continue. This is not the only thing we have to do. And these are simple analysis, very well recognized, speedy, segmentation, times, everything is covered. That surprise us, but we are seeing that in many cases they are not properly used.
Hay otras iniciativas
There are other initiatives in Canada. You have it here. If this presentation is disseminated in Alberta, Ontario, we see the concern about the appropriate use and how we can improve and avoid doing what we shouldn't do. How to do things properly and do well. And now we are also seeing the opposite of how to avoid it. This nice initiative do not do. You have all the negative recommendations, and they have a sort of they are in a document, do not do, which I think is very, very interesting if you want to see it. I can speak about all of the initiatives, but time doesn't permit. In this today, we will be able to share more information. What are the factors affecting the influence and the impacts of the technology assessment? Of course, we have to speak the same language. The question has to be clearly posted. We have to be clear enough with the person on how to approach the dimensions to be assessed, about the agenda, and what we can use, and what we can offer in the deadline. From today for tomorrow, we can do miracles. We cannot do miracles. We have to validate the question with the experts in the area. We have some examples. The ministry issued one question, and the field said, no, that is not the main concern. You have to see it in another way. We went back to the ministry. You are not asking the question properly. No, we want to do it. We did it. Wasn't useful. We know that we don't have to always listen to the person who poses the question in order to avoid useless work. The technical quality and conclusion have to be realistic. We cannot conclude a recommendation that is not a place, timely responses, involvement of the stakeholders, and finally this dissemination and transfer of knowledge and mobilization, which is a word that is being used a lot now. I don't know here, that means to say, that means mobilization. The knowledge has to be shared with all the stakeholders from the beginning of an assessment exercise, and not only at the end of the exercise, just to tell them, well, here is the result. This is what we call, or we name as mobilizing knowledge. Now, something, I hope you can see this properly. If you have great groups, what we do in INESSS, we have the medicines, laboratory tests, and technologies, other technologies, either in health and social services. I forgot to put here. Which is the origin of this request? The assessment bodies and the decision bodies. The origin is always the manufacturer. The manufacturer goes to INESSS asking for an assessment. The INESSS carries out the assessment with an identified mechanism according to the law. The INESSS sends the report to the ministry. Laboratory tests are somewhat different. Laboratories ask the ministry to incorporate an analysis, a registration. It is called the it's a registry which is covered by the system, and the ministry asks the INESSS through a formal mechanism established by the NEC, not by the law. There is an agreement between the ministry and the INESSS. The recommendation is always addressed to the minister, who will make the decision. In terms of technology, the request may come from establishment, from the ministry, professional associations, and also patient associations. INESSS carries out the assessment. There is some specific mechanism for that. They issue the recommendation not only to the person who asks for it, but to the decision maker, for example, the minister, which is the Quebec insurance system, because they are going to pay for the system, for the services. Everything goes through there. Which are the criteria used during the assessment? They are similar but different. for each one of the groups. Medicines are registered in the law, the therapeutic value. If there is no value, then it is abandoned and it's rejected. If the therapeutic value is good, we will see if the prices are fair, the consequences on the list of medicines which are covered vis-à-vis the other components of the health services. That means to say the budget impact and the comparison between what is lost and what is gained when that technology is incorporated in terms of cost of opportunity, we call it. If we pay 200,000 for this, we are going to have to reject 8 beds for readaptation or whatever it is in the health system. What we
En las pruebas de laboratorio,
in the laboratory tests,
la oportunidad
finally the opportunity in terms of the legislation, because the law says why we should incorporate technology, this has to stick to the exigencies of the law. 3 more minutes only. Well, I will go very quickly. We have the 2 final slides. I will try to do it quickly. Everything is interesting for me.
Entonces, en el laboratorio es
So, in the laboratory, we have the typical assessment of diagnostic exams, clinical validity, the consequences on the health system, costs also. And in technology, the typical thing is efficiency, safety. I go very quickly because I want to show you this, which is a summary of the medicines. Manufacturer presents the medicine to the regulatory organizations. Health Canada, if considers that it is a good medicine, authorizes the marketing and selling of it and prepares the response to the manufacturer saying, yes, you may market it and sell it. Then the manufacturers in each province of Canada will present its medicine to the ministry or to the assessment organization. In our case, is the INESSS that with a committee, multidisciplinary committee, will provide a recommendation, consulting all the groups, associations, and so on, and we prepare a recommendation to the ministry that will have a decision of including the medicine on the list. Manufacturer, at the same time, has to present it to a federal organization, which is the Council of Prices for Patented Medicines. This organization doesn't determine the price, but with a good public methodology, they say what is the maximum price to be applied in the province. And the prices in Quebec are determined by the paying organizations, which is the disease insurance system, and also they manage the medicines insurance system. They have a price, and the manufacturer establishing the list of medicines. This list of medicines has over 7,000 drugs because they are added, but they are never taken out. So the discussion is now, how are we going to do to take out some medicines? There's many things also to mention, but perhaps during the question and answer session, new things appear. The medicines system, I think it is important. We have 2 lists, one for the establishment and another one for the first aid officers. There are some exceptional medicines that we have them on the list for precise cases, for specific cases. And in that case, the doctor has to fill in a document saying what he is giving this medicine to the patient. The problem of these exceptional medicines, it is very difficult to control them. And also the exceptional patients, when in the case of, for example, compassion, there is a mechanism for an exceptional patient, in the case of exceptional patients. There are many things to be said with the generic medicines, but I'm not going. Aurelio doesn't allow me to continue speaking. Now, just to make a comparison, what happened with the technologies that are not pharmaceutical? Here we have the manufacturer will present its technology to Health Canada in order to obtain authorization for commercialization, and then the manufacturer will present the ministry a technology, and the ministry and the insurance system or the establishment directly, in many cases they go to the establishment. Any of them may, INESSS may consult in order to assess the medicine. In this case, it is an assessment that follows a different path, if it is a laboratory analysis or any other health technology. There is always the consultation with the stakeholders, major stakeholders, and finally all the recommendation goes to the ministry, and the Ministry of Health makes the final decision. To conclude, technology assessment is an organized activity which is at the service of decision-making entity. It has to be well organized. It has to mobilize knowledge, that means to say share knowledge, scientific and experimental knowledge. It has to be used efficiently in order to resolve complex situations. As I said before, and it doesn't have to limit to the economic aspect. This is some dangerous thing because the economical aspect may seem too interesting, but we may forget the rest. And it has to be public, reports, methodology, conclusions, and available to everybody, including some major topics that may be written in such a way for the people to understand, for the public to understand. And I didn't mention during my presentation the international cooperation. There is international cooperation in different regions, here in Latin America, in America in general, in the American continent. We have a network that allows us to share problems, and trying to find the right solutions, and sharing the work that each one of you are doing in your countries with the cooperation of PAHO. And this should be not interrupted. Now I leave you with an image that you know Rio de Janeiro probably is very strange. This is the winter, snowy winter, but this is what I have to see when I go back home. Thank you very much.